So good morning. My name is Mary Ann Lindeblatt. I'm the Director of the Division of Healthcare Services within the new Medicaid Purchasing Administration. And I have the pleasure today to introduce our speaker, but before I go to that, I just want to do a couple of housekeeping things. First, if you haven't done so already, you can sign up for Department of Personnel credit for this training at the table in the lobby in the back. And there's also some CEUs that are available for licensing and certified staff if you want them. And those certificates will be available at the end of the presentation for pickup. And I just also want to let you know that both of these sessions are being videotaped for use in later trainings. And so if you have questions, we want to make sure you use the microphone, and it'll be in the back there when we get to that point. So now for our speaker. One of the first priorities in the DSHS Vision statement, which I'm sure most of you, if not all of you, have seen, is behavioral and primary health care integration through person-centered healthcare homes. To reach this goal, we need to develop a common foundation and a common framework of knowledge about how the person-centered health home works and how we can approach redesigning our service delivery system. And that's what today is all about. This is the first in a series of 2 large meetings to get us all grounded in with the same foundation. And today, to do that, the Mental Health Transformation Grant has provided support to us to engage Barbara Maurer of MCCP Consulting to help us build the foundation for integration. Barbara is an MSW and a managing consultant for MCPP Consulting, a Seattle firm that is nationally known for its work in delivery system development and improvement. She serves as a senior consultant for the National Council for Community Behavioral Health Care on this topic. She is nationally active in writing, training, and consulting on primary care and behavioral health integration. And prior to her consulting practice, she was the senior administrator at Group Health and headed the public mental health, substance abuse, developmental disability system for King County. She has written or co-authored articles on behavioral health care, performance management, and the integration of primary care and behavioral health care. So I think we really do have the expert in this field today and for our next meeting, June 28th. So I'm very excited and pleased to be able to introduce Barbara Maurer, who will be spending the next few hours with us. Thank you, Barbara.
Thanks, Mary Ann. It's great to be here, and as I was out, as people were registering, seeing familiar faces, so it's exciting to have this opportunity to have a conversation about integration, and we have some feedback. Go through a series of slides and then stop for questions. We're going to take a break midway through this session in case you were thinking that you were going to be locked in this room for 3 hours. And so it'll be a combination of my doing presentation, then doing some Q&A, and then moving back to presentation again. So if you have questions as I'm going along, you may just want to jot those down on your handouts. You've already heard that the Transformation Grant is supporting this project, so thank you, Transformation Grant. Ron, are you in the room? Maybe he's coming this afternoon. And we've got the context of the department's vision for safe, healthy individuals, families, and communities, with one of the priorities being the one that Mary Ann just referred to, the others being quite related to that set of priorities. And we'll be talking actually about the interrelationship of some of these issues as we go along today. Just to give you a sense of where this whole process is going, we're doing these 2 training sessions, one in May and one in June. And then there will be an additional set of work sessions that will be done with the integration implementation team and dissemination team. And the result of those work sessions will be, by December, a policy framework, an integration policy framework that would be a resource for any of the state agencies that are going to be involved in the implementation of healthcare reform. And there are multiple agencies that have a role in all of this. So we'll be working with the issues that will cut across during these 2 trainings, but really trying to wrestle with some policy options for Washington State going forward. You can see here that what we're going to cover today is, first of all, an overview of healthcare reform, because it's an incredibly important context for having a conversation about healthcare homes. And then we're going to talk specifically about service delivery redesign in relationship to healthcare homes. When we come back together in June, we're going to dig further into the components of integration, which are really clinical, operational, and financial, and look at some issues in each of those areas. And we'll end the second session with a presentation by Marianne and/or Richard, maybe they'll be presenting in tandem, talking about payment reform, the payment reform pilots that are going to be starting here in Washington State, because those are relevant to this topic as well. So what we see as we look out into the future to 2014 is that there are two forces coming together, healthcare reform and the passage of parity, that changes almost everything about the assumptions that we've had for organizing and delivering services in the past. What we know is that we're getting attention to the issue of the healthcare needs of persons with serious mental illnesses, and we'll talk more about that this morning. We also have increasing attention being paid to the mental health and substance use needs of all Americans. And you'll see some data about that in the course of this discussion. What we think is going to happen is that this will really change the way mental health and substance use services both are funded and where they fit in the healthcare ecosystem that we'll be developing. So you've already got a lot of work underway in Washington State. You've got a collaborative going on right now for medical homes that's co-sponsored by the Department of Health and the Washington Academy of Family Physicians. You've got the planning stages underway for payment reform pilots. And you've been a national leader here in the department with disease management and chronic care management ideas. You've got the Rethinking Care projects, the chronic care management program that's an ADSA. There's a lot that you've been working on. And I just want to stop and say, how many of you in the room are involved in one of those projects that I've listed here? Okay, so there's a small set of you who have been real close to this stuff, and maybe a lot more of you who haven't been close to this. This is going to be interesting. Why does it matter? Well, it matters because we've got the quality and health disparities for the population with mental health and substance use conditions. We've got the cost of both health and mental health and substance use care with limited funding resources. And while it's been very painful here in Washington State, I'm sure most of you know that it's been even more painful in some of the other states that are facing these exact issues. Right now in California, what's on the governor's budget is a 60% reduction in mental health spending. So we've got the promise of healthcare reform and this current very difficult economic situation in the states that people are trying to grapple with. How do we move forward when we're in this kind of situation? I do think we will have different expectations of mental health and substance use providers in the future in terms of the kind of care they provide, where and how they provide it, and it's likely that the structure is going to have to shift as a part of doing that. So let's talk first of all about these three key elements of healthcare reform: universal coverage, payment reform, and delivery system redesign. The first and most important thing for us to wrap our heads around is the coverage expansion issue. And while this will vary by state, the overall analysis suggests that the Medicaid non-elderly enrollment will be 46% higher in 2019 than it would have been without the new law. And that's because single adults who are poor will be able to obtain Medicaid expansion coverage. So if you're a single adult and you're poor, under 133% of poverty, you won't have to go through the disability hoops in order to get Medicaid coverage, Medicaid expansion coverage. And that's going to have a huge impact in the mental health and substance use world, because many of the individuals that they serve are either uninsured or go on and off of Medicaid coverage depending on what's going on in their lives. So for example, if they're in the criminal justice system, then they lose their status and then they have to start all over again, and you all know that story. So we will have, I think, probably many of the uninsured who are currently served in the mental health and substance use system having coverage in Medicaid expansion, which is up to 133% of the federal poverty level. And then the subsidized plans through the state health insurance exchanges will provide subsidies up to 400% of poverty on essentially a declining subsidy as you go higher up that scale. So lots of folks currently not insured needing services will get services. Our estimate in looking at the uninsured population, and this was an analysis done for the National Council for Community Behavioral Health Care, is that there are probably 17 million Americans with Medicaid coverage or who are indigent and uninsured that need mental health services in a year, and only a small portion of them currently have been accessing services. We think under reform at least 2/3 of those who are uninsured would shift into Medicaid or an exchange, so that would lift the coverage level to 84%. You can see in the detail here that the analysis that we have done is to sort the population, both Medicaid and the uninsured population, into those with serious to severe conditions versus mild to moderate. And it's the mild to moderate who particularly have had difficulty accessing services in the past and would then be able to access services in the future. So we've got this expansion in Medicaid. Then we have the implementation of parity. And between the federal parity legislation and specific components of healthcare reform, we essentially have a situation in which parity will cut across almost all payers, across large employers, across Medicaid, in the health insurance exchanges, and Medicare limping along in its different kind of pathway, but on the way to parity. And when we think about parity for the populations that will be being picked up in terms of insurance, we need to keep our eye on what's called the benchmark benefit package. Because the way this is structured is that Medicaid expansion and the health exchange plans can use what's called a benchmark benefit package, which means it isn't a full scope Medicaid package necessarily. So what benefit package gets selected, and this is a state level decision, will be part of what you'll want to keep your eye on when we think about what kinds of mental health and substance use benefit will people have. Payment reform comes along behind that coverage expansion with the intention of both improving quality and managing costs. So the intention as the payment reform discussion has gone on is that there needs to be payment models put in place that will help bring down the overall cost. And you will see and hear it referenced as bending the cost curve, because the projections have costs going up like this. So it's not about dropping them below their current levels, it's about bending that curve so that they don't go up on the same trajectory that they are on right now. We have pilots underway already in terms of payment reform. Medicare has just kicked off its medical home pilots, which have a payment reform, significant payment reform component to them. We have commercial and self-insured plans having been running some pilots. You all may have read about the Boeing pilot and their experience in terms of cost reductions when using the medical home model. And the insurance exchanges, larger Medicaid programs, and possible dual eligible plans will be the state incubators of design changes. So there's a lot of activity going on. There will be more going forward in the future. And there are questions that none of us really know the answer to at this point, like how will Medicaid programs implement parity in medical homes? Pilots going on in some states now, pilots getting going here. How many uninsured will go into the exchanges? How many dual eligible plans will develop? And will mental health and substance use providers be on the exchange and dual eligible provider networks? Let me say that again. Will mental health and substance use providers be in the networks of exchange plans and dual eligible plans? If you think about what I just told you about the uninsured and how they're going to be picked up for coverage and the degree to which we think many of them will have mental health and or substance use conditions, then having mental health and substance use providers as a part of those networks of providers will become significantly important. A part of this whole payment reform conversation is about what's called inverting the resource allocation triangle. So you see up here the current resource allocation. This is, the national healthcare dollar, with the bulk of the resource being spent on acute care, and then on specialty care, and then a small amount being spent on prevention and primary care. The intention is to flip that triangle over time and reduce the amount spent on acute care, on specialty care, and broadly expand prevention and primary care. When you look at data from other countries and look at the relative proportion of primary care providers to specialists, what you see is that there's actually better health status in other countries and in parts of this country where the proportion of primary care docs balances the proportion of specialty physicians. There's data that shows that in this country, if you take a regional health area, the greater the proportion of specialists, the lower the health status of the people who live there. So there's a reason for this inversion of the triangle, and that is if we want to improve the health of the population, we need to really dramatically shift the way services are delivered. And you'll notice that it's in bold letters here. That kind of shift isn't going to happen by magic. Nobody's going to say, Mary Ann's not going to say, presto changeo, Washington State, and it'll all be different. There's so much work to be done to think about how you carefully move a system forward so that people don't get lost in the change process and we don't do harm rather than doing good. There's a couple of key ideas about payment reform that are at work in the land, and whether or not this is exactly how this will play out in Washington State remains to be seen. But the most prevalent model that's being discussed for payment reform for primary care is that medical homes will have a three-layered payment system. So the three-layered payment system would be, you would continue to bill fee-for-service for the regular CPT-coded services that you provide as a primary care clinic. You would get a monthly case rate payment that is related based on the population of enrollees you have in your medical home. And that case rate payment covers prevention, early intervention, care management for chronic conditions. So it's where you put a lot of the activities that right now don't get funded because there's no code to bill it for. So you don't get paid for doing it. This, instead of trying to turn it all into widgets, it turns it into a wraparound case rate payment. The third layer is a bonusing structure. And the bonusing structure would be related to achieving quality targets and sharing in the savings of reduced total health care expenditures for the population that's enrolled in your primary care clinic. One of the discussions that's going on about this three-layered model is what should the relative proportions be that we think people will be paid. And the experience in Britain has been that the primary care docs there get about 20 to 25% of their income on the bonusing structure. and that if you make it at that level, that really does change performance in primary care settings. So that's a piece of what the payment reform conversation is about. A second piece of payment reform is more about hospitals and specialists. And the conversation there is about bundling payments to hospitals and specialists. And so you would pay, if you're going in for a knee replacement, then it would pay for all of your surgical and medical expenses as well as the hospital expenses for having your knee done. And it would pay for the 30 days after you were discharged, so that if you were readmitted, if there had been an error in your care, that would not be rebillable. That would just be covered in the bundled payment. So part of what they're trying to get at here is an issue called potentially avoidable complications, which have already been identified in a number of the key procedures that are hospital-based, and an attempt to deal with the fact that, especially for older adults, many patients return to the hospital within 30 days of discharge, mainly because care transitions from hospital to the community were not well thought through and developed. Some of this is starting to be piloted already. In California, there are some initiatives starting where hospitals are going to be getting bundled payments for specialty services. Which brings us to accountable care organizations, which are kind of somewhere on the cusp of service delivery design and payment reform. In part, they're intended to create entities that can bring together medical homes, specialists, hospitals, to manage and mediate some of these new payment methods. So according to Congress and CMS, an ACO would have at least one hospital, a minimum of 50 docs, a mix of primary care and specialists, commit to be in business for at least 3 to 5 years and serve at least 5,000 patients. And if they met pre-established quality goals, that's where the incentive payment would go, and then it would be inside of the ACO that the decisions would be made about how that incentive payment was split up. Medicare will be, under healthcare reform legislation, organizing ACOs to begin in 2012. That's like right around the corner if you think about how much of a change that represents. And Medicaid will also be beginning demonstration projects around the country that use the ACO concept. What that means in terms of what kind of organization this might be is that it's going to be a separate legal entity with ownership and governance that's shared, for example, by the hospital and physicians. The implication is that they have to have a very robust IT system to track patient health care. They need to be able to provide both primary and specialty, multi-specialty care, and deal with those bundled payments and how they're going to manage bundled payments. It requires having a staff that's separate from the providers that are a part of the ACO, and it needs to integrate and align the interests of all of the members of the ACO. This is, again, a new animal. There's probably the closest thing to it that I could point you to right now is the work that they've been doing in North Carolina with the community care networks. North Carolina being a state that has lots and lots of 1 and 2 doc shops, lots of very small primary care practices. And so they've implemented the concept of the medical home and somewhat of the ACO concept by creating these community care networks that are made up of hospitals, primary care docs, specialists, and that provides some of the supportive resources for the practitioners to be able to work in this kind of payment environment. ACOs would be needing to analyze patient experiences across the population and really lead the way on quality improvement strategies. So, for example, the CCNs in North Carolina have been the locus of projects focused on diabetes control or asthma, And those are the kinds of things that an ACO may do, which makes it possible for small practices to participate in this new payment and quality measurement environment. They will need to be able to tackle this fragmented payment and delivery system and really help refocus the system on improved outcomes, better quality, and reduced costs. And again, the question is, will mental health and substance use providers be a part of ACOs? Will they be at that table? And will they be there advocating for bidirectional integration? Our own sense of that is if they don't get there, if they don't go out and figure out what's going on with ACOs in their communities, they're going to wind up not a part of the system overall, and that will be a problem because the services really do need to be better integrated, and we'll talk about that as we move into talking about medical homes. So medical homes are going to live in this larger healthcare system that I've just described to you, where they have a unique payment model. They're going to have linkages to high-performing specialists, and they're going to be relating to hospitals that have bundled case rates. And the thing that's driving everything that sits underneath this is improving quality and managing total health care expenditures. So the medical homes are built on a number of key ideas. One of them is the care model, which was developed by Ed Wagner in Seattle, the McCall Institute, which lays out the idea that in order to deliver good care for people with chronic ongoing health issues as opposed to acute issues, you need to have a whole series of structural pieces in place. It moves you away from a doc to team-based care, to having a team that is responsible for the care of a population and having these key components: clinical information systems, decision support systems, a delivery system that's been designed to support team-based care, self-management supports for the individuals that they're serving. So this is a set of key ideas that has driven medical home thinking. Another set of ideas that has driven medical home thinking are those that came out of Crossing the Quality Chasm several years ago, which are the Institute of Medicine's 6 aims: that healthcare be safe, effective, patient-centered, timely, efficient, and equitable. So you'll see you're starting to see now where some key phrases keep repeating themselves over again. 10 new rules were postulated in the IOM report, and it's important for you to know, if you think about how our environment is changing, that the Institute of Medicine Crossing the Quality Chasm work was chaired by and really driven by a guy whose name is Don Berwick. How many of you have heard of Don Berwick? A few of you. So Don Berwick, out of Boston, created this organization called the Institute for Healthcare Improvement back in the mid-'80s. And back in the mid-'80s was a time when healthcare organizations were beginning to think about adopting quality improvement technologies to improve the quality of care. And Don organized the Institute for Healthcare Improvement, and it's been the national leader in working with providers, principally commercial private sector providers, to improve the quality of hospital care, to improve the quality of primary care, and they have developed a whole set of methodologies around doing this. But this is a guy who's very driven about quality and about patient-centeredness, and he's the designated appointee to head CMS. So think about that for a moment. Think about the fact that the person who is going to run the gauntlet of the congressional approval process, but the guy who's now up to be the head of CMS, oversight of payment, created these rules and believes this is the way we should run our healthcare system in this country. It's going to be an interesting ride, folks, to see what happens. Another thing that Don led is the creation of this concept called the triple aim. And that's taking all of these more complex ideas and boiling it down to, here are 3 bullets. This is your elevator speech, 3 bullets. Improve the health of the population, enhance the patient experience of care, reduce or at least control the per capita cost of total health care. So this is the mantra that they have been working under for the last several years. And all of these ideas are informing this idea of the medical home. Now, the major physician groups in this country came together in 2007 and agreed on this set of principles for the patient-centered medical home. That there's an ongoing relationship with a primary care provider. So there's the idea of continuity of care here. That there's team-based care, that team either provides all health care or makes appropriate referrals, that care is coordinated and or integrated, that quality and safety are the hallmarks of practicing in a medical home, that enhanced access, 24/7 access of some kind is available, and they added on, by the way, we'd like to be paid for doing this differently. And you've already heard about some of the payment reform ideas. If you're interested in learning more than you ever wanted to know about the patient-centered medical home, you can go to the website that's listed on the bottom of this slide. The Patient-Centered Primary Care Collaborative is the national organization that has been moving this medical home idea forward on a very fast track. It is made up of major employer groups, all of the major health plans, all of the major physician groups, national consumer representation, and they are really pushing that model out in various places around the country. The chairman of the PCPCC is in charge of healthcare purchasing and strategy for IBM. So that gives you a feel for how they have brought together purchasers of healthcare and the plans and the providers around this idea of a medical home. So what you'll see here in the next couple of slides is some thinking as articulated by a variety of people about what this transition represents. And I'm certainly not going to read this whole slide to you. This is from Tulsa, Oklahoma, from the School of Community Medicine there. And what it talks about is how are we changing the construct from today's care to patient-centered medical home care. So let me just take the second row, for example. Patient's chief complaints or reason for visit determines care. That's pretty much the way the healthcare system works right now. We systematically assess all our patients' health needs to plan care. Different model in which there's tracking and outreach that goes on as a part of delivering care. In Maine, they have been running a Medicaid medical home pilot for a while now. They have, I think, 20 sites, 20 practices up and going. And what they did in their design of their medical home model was to put together the two pieces of practice transformation and payment reform. So they're testing both things in their medical home model. And one of the things I really like about these main slides is that they have taken on head on the question that I frequently have been asked, which is, well, this medical home thing is, aren't we talking about capitated primary care all over again, the old managed care stuff that we all lived through in the early 90s and we all had so much fun with? And I see heads nodding. You had fun then, right? And so here's a nice way, I think, of going through the distinctions. It is absolutely true that in the 90s managed care version, we had a focus on reducing costs. What is envisioned here is a focus on demonstrating value. Global capitation was one of the methods that was being used, which is that primary care physicians, depending on the state and the models, were at risk not only for what they did as primary care docs, but for what specialists did and for what hospitals did. The idea here is that you parse that, you split that apart, so that primary care practices are responsible for what they do and for their population, but they're not gatekeeping access to specialists and hospitals. If anything, they may be trying to get you faster to a specialist because of the quality outcome that they want. So you don't have the PCP at full financial risk. You have a more limited financial risk model. You don't have the PCP as the gatekeeper. It's much more of a coordinating model. And one of the things that has really changed a lot is the role of information technology. Because at the time that everybody played this game the last time, we were still in a paper record world. But now, a big piece of becoming a medical home is having the information technology to support the care that you're delivering. And you'll see that in just a moment. Here are the core commitments that Maine required of those participating in their pilot. And I love them because you will notice that number 6 said that they expected all of their medical homes to include behavioral physical health integration as a part of what the medical home was doing. They convened a payment reform commission, not unlike what's going on here in Washington State right now. One of the things, of course, I said this to Mary Ann the other day, it must be a lot easier to do something if you're Maine or Vermont, right? than it is, if you're Washington State or, God forbid, California. So they essentially have mainly four plans plus Medicaid that are the payers in Maine, and they had all of those payers at the table, and you can see that they agreed on the 3-component model that I just showed you earlier as the way in which they're going to be paying those medical homes. Now, coming up is an opportunity, actually very quickly in 2011. One of the things that the health reform bill does is establishes a state plan option for the state to have medical home pilots. And what's interesting about this piece of the legislation is that it specifically calls out that the individuals who would be eligible to be in these pilots have at least 2 chronic conditions, have 1 chronic condition, risk for a 2nd chronic condition, or have a serious and persistent mental health condition. And it also specifically calls out, when you look at who can be a health home, that a community mental health center can be a health home. So we're beginning to head our way now in our conversation today towards this idea of healthcare homes. And having a couple of different models of thinking about where is this healthcare home and how does that get delivered. The services that are provided here are listed here. Don't need to read these to you. This is an option that will have 90% FMAP for the first 8 quarters, and then it's going to revert back. And by the way, I didn't say, and I assume most of you know this, but you may not, that at least initially for the Medicaid expansion, that's 100%, beginning in 2014, 100% FMAP, and then it steps back down to 90 over time. So it's a different matching formula to do the Medicaid expansion. So all these pilots are going on. Now, who decides? Who gets to decide, oh, you can be in the pilot because, yeah, we think you're a medical home? Now, that's a really important question. We're going to start playing around with all these new payment methods, is how are we sure that we're paying for the same thing here as we're paying for here as we're paying for here? And so one of the other pieces that got put in place over the last couple of years is a set of certification standards for the primary care medical home, patient-centered medical home. There are a couple of other assessment tools out there for medical homes, but this has really emerged as the principal certification structure. And NCQA, as you may know, currently is an accrediting organization for managed care plans. They also accredit special needs plans. They accredit managed behavioral health care organizations, and they've had a number of initiatives going on over the last several years in which they're working at the provider level to improve provider level capacity for both quality and tracking of status. So what practices have to do in order to be in most of these major national pilots is be certified by NCQA. And you may have noticed as I flew across Maine that was one of the requirements they had, that you had to have a certain level of NCQA certification. So this is tiny little print even on my screen, but let me just hit the high points. Standard 1 is access and communication. Standard 2, patient tracking and registry functions. Standard 3, care management. Care management, and you'll hear me say some more about this today and a lot more about it in June, is a key function in medical homes. Standard 4, patient self-management and support. Standard 5, electronic prescribing. 6, test tracking. 7, referral tracking. 8, performance reporting and improvement. 9, advanced electronic communications. So you can see the technology stuff and how it's woven into these requirements for the becoming certified as a patient-centered medical home. The bolded ones are the must-pass ones. Those are the ones that you must pass in order to achieve certification. Now, interesting stuff going on with NCQA, because these are relatively new. But people started saying last year, at the beginning of last year, well, you know, there's really not anything in here about mental health and substance use and integration of services and how that fits in. So here's an update from the field. In December of last year, the American Academy of Family Physicians wrote to NCQA with a number of suggestions about improving the standards, and the letter included this statement: an emphasis on incorporating mental health and behavioral health into the standards, which we believe are conspicuously missing from the current standards. Second, the PCPCC sent proposed changes last fall. The beginning of this year, the Carter Center Medical Home Summit Steering Group sent proposed changes. And the response from NCQA to the Carter Center was, we will include behavioral health in the revised standards. And we expect to see those new standards posted for public comment by the end of this month, and they will be in play beginning in January of next year. So part of what has happened in this very brief period of time of launching the concept of medical homes, getting pilots going, getting certification processes going, is that we have successfully also gotten mental health and substance use on the radar screen of these key organizations, and it'll be a part of the certification standards in the future. It's also showing up in other places around the country, in the states, and you have a couple of pieces from Oregon here in the slides and in your handout. They just, in February, released their standards and measures for patient-centered primary care homes. And these are the core attributes of those. And one of the things I really, really like about their document is that they've used person-centered language throughout. So what does access to care mean? It means be there when I need you. What does accountability mean? It means take responsibility for making sure I receive the best possible health care. And the whole thing is written in that kind of person-centered language. So just staying with the Oregon stuff for a moment, let's drop down to see what the standards are for each of the core attributes. So you've got access to care, accountability, comprehensive whole person care, continuity, coordination and integration, and person and family-centered care as the core attributes. And if you take a look under coordination and integration, you'll see that has three pieces to it: data management, care coordination, and care planning. So let's dive down a little further and see what coordination and integration means in terms of the kinds of standards that they're looking for. You can see the standard for data management. You can see the standard for care coordination. Look at the second bullet. When I need to see a specialist or get a test, including help for mental health or substance use problems, help me get what I need at your clinic whenever possible, and stay involved when I get care in other places. So again, I want you to stop and think about what a sentence like that means in terms of where we may be going in the future in regard to mental health and substance use services. Because the implication is clearly, in Oregon, as they move medical homes forward, that their expectation is going to be that inside of the clinic there is capacity for mental health and substance use services, and there's a referral process for a higher level of care in which the primary care physician gets to stay involved, unlike what happens now most of the time. Most primary care docs will tell you that when they refer to an outside mental health or substance use program, it's like a black box. They never know what happens. They never hear anything back. It's like, oh, I don't know what went on. So that's where the world is going in terms of medical homes. Now, as you might well guess from what I've just walked you through, this is not, again, going to be magical, and it's not going to be easy. So there's a great article that came out last year that tells us just how hard change is going to be. And they worked with 36 family practice sites that were going to transform to medical homes. And you can see here the 6 things, the big themes that they learned from that work. It does require transformation. The technology is not easy. It's not plug and play. Most of the technology out there doesn't yet quite support these ideas. Transformation to the patient-centered medical home requires personal transformation of physicians. And let me just add, and I'll be talking more about this after the break, for mental health and substance use providers who work in primary care settings, it requires transformation for them as well. This is different work. Change fatigue. I know nobody in this room is familiar with change fatigue, right? Never heard of that. No. Is a serious concern even when people are really highly motivated. Transformation is a developmental process, and it's a local process. Now, when I read these 6 things, I thought all of that is exactly the same thing we've been seeing in integration work, the work people have been trying to do to bring mental health into primary care homes or take primary care into mental health organizations. So it really, we've got the same sets of issues here, and ideally what will happen is that the integration initiative will get woven into the medical home initiative so that it's all a process of change, but at least it doesn't feel like 2 disconnected kinds of changes. It's a single change that has all of the pieces fitting together. And so now I'm going to stop and see what questions you have. And you're going to use the mic, I think, if you're going to ask questions. Right, Glenn?
Yes, please.
So does anybody have any questions? Or was this all like, oh, we already knew all of that, Barbara?
Can you talk a little bit about the supply of providers to the increase of patient loads that you see coming over the next 5 to 10 years?
Boy, what a great question. So let's start with primary care docs. There aren't anywhere nearly enough of them. And as many of you may know, what has been happening over these last few years is that as medical school graduates are choosing their next step, it's not been to go into primary care, it's been to go into specialties, because the payment system in this country drives people towards specialty. The specialties are what get well reimbursed. Primary care does not get well reimbursed. So there's really 2 or 3 at least strategies here. One of them is this whole flipping around to a medical home and starting to reimburse primary care docs to do the work that we want them to do and to make it a viable job and profession. The second thing is that there is a truckload of money in the healthcare reform bill that is about education and improving the pipeline, opening up the pipeline to move more people through in terms of producing primary care providers. The second piece of your question, the implicit second piece of your question, is that it isn't exactly as if we've got a lot of mental health and substance use providers hanging around, not having anything to do. And so we have a very similar kind of set of issues when we think about trying to integrate mental health and substance use services into primary care settings, and that is, where are we going to find this workforce, and where are we going to find the workforce that's trained to do this work this way? And there is some money also for that in healthcare reform legislation, but it's a huge workforce initiative that we're going to have to grapple with across the country, really. So great question, no easy answers on this one. Yes?
Hi, Barbara. Good to see you. I'm Jan Norman from the Department of Health.
Jan, good to see you.
Yeah, thank you very much for that wonderful overview of trying to connect all these moving parts and pieces. And the one that really felt like a disconnect for me was the Accountable Care Organization date of 2012 in the federal reform legislation, trying to implement that early in the process. I know our state has its own law around setting up 2 pilots for accountable care organizations, and the date on that is right on top of that date. So looking in your crystal ball, how do you see those 2 things reconciling? Because I can't even imagine at the federal level putting in ACOs that quickly.
You know, I think it may well be that the ACOs in the federal initiative may develop around some of the medical home initiatives that they have going, that they may build around that. Can't tell you more than that at this point. It is a challenge. And then I should say one other thing, and that is, in California, ACOs are already forming. There are ACOs that have already started announcing themselves, that have brought together providers and hospital systems. So in some markets, this may be on a faster track than it is here, and those may be some of the early pilots as well. They're flipping a coin here or something, I think.
I'm the interpreter.
Oh, okay.
Just trying to set it so I can see her.
Okay, great.
Looking at the NCQA Certification Standards for the care centers, before I go ahead and ask the question, I'd like to give you some context. Chronic care, either public health or mental health, continues to be an issue for deaf and hard of hearing individuals, a huge issue. And looking at the certification standards, the standard number 4, patient self-management support, how can that be so low? Because language access is huge. It's very important.
So let me be sure I understand your question. Because I don't know that it is considered low. They have a clear subcomponent in here on assessing language preference and other communication barriers. It's not one of the must-passes. Is that the question you're asking? Why isn't it a must-pass?
Yes.
You know, I think the dilemma here is that probably many of us would say they should be doing all of this. Everybody should be doing all of this. But it's going to be a developmental process. So they had to settle on a starting set of must-pass criteria. And there are actually 3 levels of certification. So there's the entry level of certification, and then there's the 3rd level. By the time you get to the 3rd level, you're doing all of these things, and you get paid a different case rate depending on the level that you are certified at. So the incentive is to push people up to perform on all of those.
I'm still a little puzzled, but I'll listen to the rest of the presentation before I ask any more.
Okay.
Good morning, Barbara. I'm Candy Gehring with Aging and Disability Services Administration.
Candy, we've talked on the phone so many times, and we've never met.
Yeah,
so good to meet you.
It's nice to meet you today as well. So as you know, I am in the long-term care work and world with Department of Social and Health Services. And I really appreciate, as Jan said, too, the fabulous overview that you did this morning. But I have a question and a concern as well in terms of the depth of the understanding, perhaps, of how much health care goes on outside of the physician's office, and whether or not health care reform is taking that into consideration, because the diagrams and the tables tend to stop inside of the physician's office and the provider network, and we know that much more goes on from a patient or participant-centered person's framework than what their physician is sending them to do or giving them prescriptions for. So do you know whether or not that's addressed in more detail in those references and resources you've given us about how it will look at outside the box for what a person believes is important to improving their health?
Well, there's a couple of things, Candy. One of them is, if we go back to the care model, you'll remember that a piece of the care model is community. And the intention in placing community in the care model is to say that the medical home needs to engage with the community and community resources as a part of helping people put together their self-management plans. So that piece is pretty clearly articulated as an expectation. And there's been some conversations going on about essentially medical neighborhoods, which is what's the context in which the primary care practice works, what's in that medical neighborhood or the resource neighborhood for individuals who are trying to work on self-management goals. The other thing is that I think the definition of care management is going to continue to evolve to include work in the field, which I know, for example, in the King County Care Partners, that's an important part of what they're doing. It's an important part of what the folks in your project are doing. And in a recent study, which is also summarized in your handouts, everybody, there's a study by Tom Bodenheimer looking at all the research on care management. And one of the points that he makes in there in terms of findings is that the most successful projects engaged patients not just in the clinic, but at home and in the community. So I think we'll see that evolving.
Well, and as long as I've got the mic, one other thing. I just think this is a good opportunity, too, for HRSA and ADSA to think about what those other options are for people in the community that we don't currently have as a benefit to Medicaid eligible clients. So I'd invite Mary Ann to, give me a call, and I'd love to talk with her about those. Thank you.
Hi. You talk a lot about the substance abuse and mental health services, and that there's a really great integration that's potentially there. As you talk about the provider at the provider community mental health level or the substance abuse provider level. But our current structure is through counties for those services. So how does that play out? I mean, does the new models jump? Do those melt away? You know, what happens with all of that?
That is a terrific question. Harvey already asked me that before the session started. I don't think any of us know what the answer to that is yet. And when I talk about that, remember that I'm trying to give you a sense of what the national conversation is. And so when it comes to the organization of mental health and substance use services, there is so much variation across the states in how services are organized. Just to give you a quick feel for that, just if we stay on the West Coast, in Washington, those services are principally provided by community-based nonprofits, but managed by counties that have that oversight and planning role. In Oregon, in the major metropolitan areas, they're principally provided by community-based nonprofits and managed by the counties. But in the rural areas, they are delivered by county employees. In California, most of it is delivered by county employees, with a little bit of it being subcontracted to community-based nonprofits. So, you know, very differing kinds of structures. And one of the things that you'll hear me say probably more than once is all healthcare is local. And I just can't tell you how strongly I believe that to be true given my work around the country. These solutions to those kinds of questions, to how do we organize ourselves, are going to be, I think, very local. First of all, locally at the state level, and then even more locally in a community. So we don't know the answer to that yet.
So just a follow-up question. So then there would be a state level kind of policy discussion about how they want to approach it?
Hopefully.
I mean, that's the question?
Hopefully, yeah. Yeah. I suspect we may wind up doing a little talking about that in the work groups that go on over the next 6 months. It'll be hard to do our work without talking about it. Hi.
Hi, Barbara. Frank Jose. For me, there's always the ongoing debate as to what's medical and what's covered. And it seems like a big piece of what people need is outside of this somewhere. So, for example, so many people's mental health cannot be successfully treated without a reasonable place to live.
Exactly.
The likelihood that they're going to remain low income is high because they don't have employment opportunities, for example. Or is it seen as, well, that happens in the community, is exclusively a referral mechanism?
You know, I'm going to beg your allowing me to deal with that question in the second half of what I'm going to present today.
No, I'm just kidding. Just kidding, Barbara.
And the reason for that is because what I presented to get us here is to get us all on the same page about what this national conversation is that's going on, which has been really driven by primary care and health care, in which some of us have been working very hard at the national level to say, excuse me, but what about mental health and substance use? You guys aren't even mentioning it. So we've now got them to mention it. But the next set of questions is, well, how do we organize delivery systems to answer the questions that you've raised? And I'm going to dive right into that after the break and talk about the 4-quadrant model and models for how this could look in the future. So let me take one more question, and then I think we need to take the break.
Good morning. I would like you to comment on the NCQA recognition, because I don't know if you are familiar with some comments and some criticism that NCQA has received that is very technology heavy, and then it's not patient-centered. So if we are talking about patient-centeredness, I mean, why are we using NCQA recognition that is so heavy on health information technology and leaving the patient outside a little bit? I mean, not completely, because, you know, it's talk about reminders, talk about care coordination, referrals, etc., but all that is technology. But what really happens with the patient experience and how NCQA is addressing that, because it's not clear to me how, you know, that is embedded into the NCQA recognition program for patient-centered medical home?
I think we will see that addressed in the revisions that they have said they will be putting out at the end of this month, because that was another major thrust of the comments that they got from the American Academy of Family Physicians, is that somewhere in putting together the criteria, they kind of left out the taking care of people part, and that needed to be in there too, and more clearly in there. And it'll be interesting to see how these various efforts influence one another. One of the reasons I gave you the examples from Oregon, and what you also have in your package is the set of principles that Oregon adopted in the context of their standards and measures. I think that piece of work, of putting it all in person-centered language, so that we're talking about what do patients have a right to expect from us, what is that expectation, begins to shift us towards thinking in that mode much more. So I think it's probably going to evolve, and I expect to see more in the new standards that come out. So let's take a 15-minute break. We've gotten through the big healthcare reform piece, and then we're going to come back, but please come back in exactly 15 minutes, and we'll dive into the 4-quadrant model.